Hi, everyone. Welcome to tonight's Grand Rounds with Dr. Weinberger. If anyone has any questions throughout the talk, please just type them into the Q&A box at the bottom of your screens and we'll get to them at the end. Now, I'd just like to introduce our speaker for tonight. Dr. Weinberger recently assumed the role of Director of Psychiatry at CHEMED Health Center in Lakewood. Previously, she was Clinical Associate Professor and Outpatient Medical Director for the Psychiatry Department at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia, and also maintained a secondary faculty appointment in the OBGYN department. She is founding director of Jefferson Psychopharmacology Specialty Services, a specialized outpatient clinic providing supervision, teaching, and clinical care. Dr. Weinberger completed her undergraduate studies cum laude at Yale University and attended medical school at the University of Pennsylvania School of Medicine. She completed her psychiatry residency at the Hospital of the University of Pennsylvania and a fellowship in cognitive behavioral therapy. She is a consultant for the perinatal psychiatry consultation line for Postpartum Support International, consulting with providers on clinical questions in perinatal psychopharmacology. She lectures and has several publications in the field of women's mental health. Thank you so much for coming tonight to speak to us, Dr. Weinberger.
Thank you so much for inviting me, Zara. It's a pleasure to be here tonight. Normally when I speak about issues in perinatal mental health, and that is something that we're going to cover like quickly and kind of in its basics at the end. But I thought that for this audience, it would make sense to talk about, kind of some of the common questions that come up when primary care doctors are treating patients, and some of the things that I kind of wish primary care doctors knew when they're treating patients. I'm really all about collaborative care. I think it's really the wave of the future, and there are a lot of psychiatric issues that I think primary care doctors are really able to manage quite competently, especially in the setting of really kind of a relative scarcity of psychiatrists. There's just not enough of us, kind of no matter how you cut it. So I think, education is an all important thing. So that's what we're going to be talking about tonight. I'm just trying to advance my slides. There we go. Anyway, so first thing to keep in mind, so we're going to be talking about depression specifically. I guess, just this other caveat. There are a lot of, issues that we deal with, and that, you as primary care doctors deal with as well. I think each one of them really deserves its own lecture. I'm going to talk really specifically tonight about the treatment of depression. We're not really going to focus on other issues nearly as much. That is something that I think, would be kind of beyond the scope of our lecture today. So first, I think important point to make is that depression is really a syndrome. It's a syndrome in the same way as, medical issues are syndromes. We're not looking at isolated symptoms. We're looking at sort of a combination, not necessarily all, but some combination of like a group of symptoms sort of together that, kind of combine to cause us to make the diagnosis. So in other words, depression is not just depressed mood. So I think what happens in mental health is that often a lot of the terms that we use clinically are also used colloquially and in different ways. And so, sometimes people will come in and say, I'm depressed. And that could mean lots and lots of different things. It may or may not mean that they have, depression, major depressive disorder that we would want, to think about treatment. So along with depressed mood, things that we want to screen for include sleep. So either increased or decreased sleep, usually decreased. Usually the person is trying to sleep, they're desperate to sleep, and they're just not able to. Appetite, either increased or decreased, usually, again, decreased, but it can be either. People will complain about decreased energy or motivation. They just feel like, they just can't, they're not interested. They can't sort of push themselves to do the things that they want to do or need to do. Anhedonia is a term that refers to like lack of enjoyment of like previously enjoyable activities. When somebody has anhedonia, they'll say, again, as part of their depressive syndrome, they will often say, I used to love I don't know, reading books or hanging out with my grandchildren or whatever it was. And I just don't get joy from it anymore. I don't seem to get joy from much of anything. People can sometimes have impaired concentration. Concentration is really the final common pathway of like many things that we treat. And a lot of these patients come in believing that they have attention deficit disorder because they can't concentrate. But it's really sort of important to kind of probe into that a little bit more and find out why they can't concentrate. And often excessive guilt, which can really become like a vicious cycle because, kind of because of the other things we talked about, often people aren't, as engaged in their lives as they were previously, or they're not able to do the things that they used to be able to do. And then they'll feel very badly about that, and often, kind of excessively guilty in ways that are disproportionate to what's actually going on. So, the good thing is that we've got a lot of screening tools now. The PHQ-9 is sort of one that's used very standardly. It does sort of do this screen for the syndrome for you. In order to score, have a significant score on the PHQ-9, you do need to have a combination of these symptoms, but it is, again, important to kind of look at the individual responses when possible, because, again, like just because somebody's concentration is impaired, like their concentration may be quite impaired, and that they might, gain points due to that, but they're not depressed. And so that's, again, it's a screen. It's not, it's a tool. And if somebody screens positive, then that requires, further clinical evaluation of why they're screening positive. Okay, so another important thing that we see all the time is that people who are using substances, really almost any substance, but alcohol and marijuana actually are really sort of the ones that we see a lot of, regular use of those substances, regular excessive use of those substances can lead to depressive symptoms, which will actually remit with sobriety. And so, I think often the patient won't necessarily be paying attention to that, and you might not think to ask, but oftentimes, the patient believes they're depressed, and they do have all the symptoms of depression that we would be concerned about. But in fact, if there's a co-occurring substance use disorder, we really can't make the diagnosis until the patient is sober, really for at least a month before reevaluating the symptoms. They need really sustained sobriety because the symptoms can last, for several days to weeks, et cetera, after they've stopped using. And, that person may or may not require any treatment beyond kind of helping them decrease their substance use or achieve sobriety. Again, these situations are often more complicated, but this is an important consideration to keep in mind. Other things to think about. So, older people, elderly people may present more atypically. They may, rather than sort of actually complaining about feeling sad and depressed, they may just seem more, unmotivated. They may have trouble sleeping. They may have lower energy. They may have some cognitive dysfunction. You may see some more social withdrawal or dependency on family members or friends, rather than them complaining of overt depressed mood. So those are situations that should, prompt you to consider the possibility that may be something that's going on. Coexisting medical illness is another, I think, important consideration that does tend to confuse us a bit, because, on one hand, we do know that depression, major depressive disorder is quite common in the medically ill, but often, what the patient will say to us, and what we may even think on our own, is, this person is clearly suffering, they're in pain, they're impaired, they're not able to do the things that they were able to do before. So of course they're really bummed, and like they're really sad, and they're not feeling like doing all that much. And that's a very, very fair point. But again, we want to make sure we're looking at the whole picture. So in other words, if somebody's just really sad that they can't do what they used to do, but they're able to enjoy other things in their life, and they may or may not necessarily be having other, other ones of the symptoms that we discussed earlier, then that, that's one situation, as opposed to somebody who really, kind of checks, a lot of the boxes for the depressive syndrome that we discussed earlier, even as concurrent with a medical illness, and even if the person believes that the reason that they're feeling poorly is because they're sick, that is definitely something to kind of delve into more deeply. I think the other the other important consideration here is that there can be, an overlap in symptoms. So, people can have difficulty sleeping and sort of check off that box on your PHQ-9. And, it's important, I think, to distinguish whether they're having trouble sleeping because they just can't sleep, or they're just so miserable or their mind is racing, versus, if they can't sleep because they're in pain or they're nauseous or they're getting up to go to the bathroom, that, so those are sort of, again, important considerations, like why can't they sleep? Why have they lost their appetite? Have they lost their appetite because they just don't feel like eating, or, are they really nauseous? And that's why they're not eating. So those are important distinctions to make. So again, don't assume all symptoms are due to medical illness and don't require treatment. This is something that requires careful consideration. You want to look again for that syndrome, for the constellation of symptoms. If it's unclear, then I tend to err on the side of treating, because there's really not a whole lot of downside. And there is a lot of data that indicates that concurrent depression does worsen outcomes and prognosis across a series of medical illnesses. That, people with specific medical illnesses with co-occurring depression do worse in terms of the course of their medical illness. And so treating the depression can help with their medical recovery as well. Okay. Another important consideration is bereavement, right? So, somebody who has had a very significant loss can absolutely look as if they are somebody with major depressive disorder. Most depressive symptoms are really normal in the acute phase of grief. And so if somebody's really had a very significant loss and they are, presenting with those symptoms, and they weren't having those symptoms before the loss, that wouldn't be something I would necessarily jump to treat immediately. However, the things that you want to really look for closely are trajectory in the direction of improvement. So in other words, the person sort of with time, you would expect that things would be getting, slightly easier for them. It may or may not be linear. They may get better and get worse, but sort of overall, we're sort of heading towards recovery. Suicidal thoughts are always pathological. And if somebody who is bereaved is having suicidal thoughts, that is something that requires closer evaluation and shouldn't just be normalized. Sustained social withdrawal is another kind of red flag to look out for. If the person is sort of withdrawn from their social network and they're not kind of reintegrating, within any sort of, they're not moving towards reintegration within, some time frame, that would be, I think, again, also a reason for concern. Again, right, like bereavement can, again, cause really most symptoms that we see in depression. If you have somebody who has gone through a loss and they can't sleep, I would certainly treat that. If they're not sleeping, they're only going to suffer more. And so we want to sort of treat, kind of acute symptoms to make the person more comfortable. But unless if we're seeing sort of some of those, one of those three red flags, I don't know that I would necessarily think about treating depression sort of, especially not sort of in the immediate post-loss phase. Okay, so now we're going to move on to talk about suicide and kind of how you think about a suicide assessment and some risk factors for suicide. Again, these are sort of really, really important things to kind of keep in mind when you're seeing patients. I just want to say, I should have probably said it earlier, I recognize that as primary care doctors, you're not able to ask all these questions in as much detail as we are. That's completely understandable and expected. You just don't have the time to do that. But I'm sort of putting this out there so that you can, kind of have the tools to triage and can kind of ask sort of targeted screening questions when it is appropriate. So just some background on suicide. It's the 10th leading cause of death in all age groups. It's the second leading cause of death in people ages 10 to 34. The highest risk demographic are middle-aged to elderly white males, and it's the second leading cause of death in ages 10 to 34, despite, the older white males being the highest risk demographic, because older people are, also have other causes of morbidity and mortality, more so than younger people. But yes, an older white male in particular is a demographic that we, with other warning signs, would be extra concerned about. We do know that education is protective. So, higher people who have gone through like higher degrees of education are less likely to commit suicide. Now, the exception to that are doctors and dentists. We're a very, very high risk group. And there's a lot of theorizing as to why that is. We won't get into now, but also social relationships are really protective. So people who have social connections with friends or family, or, people that they just, count on or depend on, or, can depend on, those are also people who are at lower risk. Another really, really important point is that most of suicides involve firearms. So why is that? So, I think the common thought is that really because there's no second chances, right? So often we'll see in the emergency room, unfortunately, suicide attempts by, other means where, if the person has regrets, they can kind of turn back and rethink things and kind of not go through with their attempt. With a gun, that's kind of it. Like there's really no, it's a very lethal method. There are no second chances. Firearms are the most common cause of suicide completion in men, and overdose and poisoning are the most common cause of so we don't really have really solid evidence-based algorithms to reliably assess, manage, and prevent completed suicide. These are the questions that are important to ask about just in terms of stratifying the person in terms of their level of risk. So, number one, it looks obvious, right? Desire to live or die. And, so you're like, why am I even saying that? Because obviously that's, what we're talking about here. Actually, often, when people will come in and talk about feeling suicidal, they don't necessarily mean what you think they mean. Again, this is something you want to evaluate closely, but what's very common is for people, especially people who may not have developed the best skills and frustration tolerance or coping skills, when they're feeling very, very overwhelmed and they just want to escape, they will frame that as being suicidal. And it's not like those people are at no risk. That's obviously something you wouldn't want to dismiss. But often if you'll ask the person, do you really actually want to be dead? Do you want to not be here? Versus do you just feel like you can't handle what's going on in your life now and you need to escape? Often it'll be the second. And then, sort of there are maybe then different interventions that you would institute than, if the person was actually truly, wanting to die. Has the person, really kind of gone into the details? That's another sort of important marker. Do they have specific thoughts about what they would do when they would do it? Are they, it's really, really important to ask about intent, because often people will say, I have the thoughts, but I just would never, ever act on them because, I believe it's wrong because of my religion, or because I would never do that to my child or my dog or, whoever. And so that would be somebody I would be worried about less, because, although they're having the thoughts, they know that they wouldn't act on them. Have they developed a plan? How often do the thoughts happen? Are they able to kind of recognize that, these are thoughts that they're having, but they're not anything that they're going to engage with, or that, that they're not real for them, or is the person really very, very overwhelmed and, kind of believes that, they're having the thoughts, that means they have to really, kind of take those thoughts seriously. I think a lot of people who have chronic suicidal thoughts, will, be trained sort of through various forms of psychotherapy to kind of note the thoughts and not necessarily sort of buy into them or take them, as seriously as they did before, and that can be very protective. Access to means and lethality. So really, everybody should be asked about access to guns, because we know that guns are such, like, access to guns is really, a very, very significant risk factor. Other means as well, but particularly guns. And if your patient has a gun and they're really committed to having their gun, what I would, make sure is that sort of that gun is as much removed as possible from any potential for an impulsive act. So the ammunition should be separate from the gun. The gun should be locked. Like, they should need to have to spend a lot of time accessing the gun, which is potentially time to have second thoughts. Although, we don't encourage people to have guns, but if they're really insistent on keeping their gun, that, that is a strategy. Has the person made plans? Have they, thought about who's going to inherit their belongings? Have they figured out a way so that, like, they don't, want their child to find them, that sort of thing? Those are really very concerning things. Protective factors, so like what we talked about before, like, what's keeping you from acting on your thoughts, right? Like, often people will say, again, like, I wouldn't do that to my family, or I wouldn't do it to my pet, or I just, I believe it's wrong, or, other protective factors as well, reasons why, the person can tell you why they wouldn't act on their thoughts and they, want to stay alive. Okay, so this is the Columbia Suicide Severity Rating Scale. It's sort of the best validated measure that we have. It sort of, really kind of goes through some of the criteria that, that I just talked about. And this can be, potentially a good scale if you're looking for a scale to assess risk in your patients. So some validated risk factors for suicide. So, again, these can be sort of, questions that you could ask and things that you can consider. I'm not expecting you to ask all these questions, but sort of, kind of keep this in mind. Prior attempt is really our strongest predictor of future attempts and completion. So people who have had prior attempts are clearly at higher risk. Specific life stressors that are kind of identified as major stressors, I think, intuitively, but, worth mentioning, do increase risk as well. Psychiatric disorders, again, kind of intuitive, but I think an important thing to keep in mind is that, hopelessness is actually a symptom of depression. So in other words, people who are depressed will say, like, I'm never going to get better, like, nothing's ever going to help me. Like, I know that I'm just going to feel like this forever. And that's a symptom. That's like a symptom, like any other symptom of depression. It is among the, boxes that you can check off as a symptom of depression. But it does, I think, for very understandable reasons, does further increase risk, right? Because if the person really genuinely believes that, like, nothing is ever going to change, then they're much less motivated to keep going, as opposed to people who, are miserable, but, believe that there's help out there for them, I think are more likely to hold on. Medical illness, there are, a number of medical illnesses that are all independently associated with completion. And, I list the ones that have been studied on the slide. I'm not going to read them out to you. Substance use is a huge one, right? So thinking about sort of impulsivity and its role in suicide attempts and completion. So 20%, 1/5 of suicides occur while the person is intoxicated. So again, this is, somebody who, may not be in a great place, but is, has had their inhibitions decreased significantly and maybe not be using the best judgment. And another thing to be concerned about with that is, people whose substance use escalates and it continues to escalate despite like clear consequences in their life, like their mood is clearly getting worse, their function is clearly getting worse, they're clearly alienating people in their life, and they're continuing to escalate their substance use. That is also somebody who is, potentially at higher risk. History of poor self-control and impulsivity is another really important risk factor. Again, sort of intuitive, but there are people who are sort of have sort of not learned sort of the best coping strategies, and as part of a bunch of other things that they're struggling with. And those people, may potentially be sort of at chronically higher risk. Those people are at chronically higher risk. Family history of suicide is an important one. That's another really, really important one. And we do ask people about that. Anybody in your family who has completed suicide, because it has been shown that does increase risk. Interestingly, right? It seems to be sort of independent biological vulnerability to suicide in families. Okay, so see, I'm doing the time. So when you're thinking about a safety assessment, so I'm not going to go through all of these because of the limitations of time, but chronic non-suicidal self-injury is an important one. People, again, especially people who have unfortunately not had the opportunity to develop, kind of the most sophisticated coping skills, and who may have lower frustration tolerance, unfortunately, due to, events in their life that have predisposed them to that, perhaps, are at higher risk for what we call chronic non-suicidal self-injury. So this is, it's actually been, kind of in the media quite a bit. Cutting is sort of the one that's, kind of most publicized. But any sort of like self-injury where the person will say, like, I'm not trying to kill myself, like that's not my goal at all, like that's not really, like that's not my goal at all. Often people will harm themselves with the goal of, people will say, they are in so much emotional pain, it's helpful for them to have the physical pain to take, to kind of, dampen the emotional pain. Sometimes people will say it just kind of helps them feel, they just want to feel something, they feel nothing and they want to feel something. And so that, can be a coping strategy that I would think about very differently. Again, these people obviously need, help and support, but it's a different type of help and support than somebody who's actually acutely suicidal and wants to harm themselves. Intrusive thoughts are a symptom of, it's a common symptom of anxiety disorders, where often sort of, kind of scary thoughts will pop into people's heads sort of almost against their will. Like they'll be driving on the highway and they'll imagine like running into the median, and they'll be standing at the, they'll be standing in the kitchen and they'll see a knife on the counter and they'll have a thought about stabbing themselves or stabbing somebody else with a knife. And they're horrified by those thoughts. It's the last thing they want to do in the whole entire world. They often will not disclose those thoughts because they're concerned that other people will think that they're in danger. Those people are really, again, require help, but are, not necessarily a danger to themselves. It's the last thing they want to do. And so they're not really at increased risk for harming themselves or anybody else, but we do need to address sort of the core cause of the intrusive thoughts. And then people who are psychotic, who are having any sort of thoughts about harming themselves or someone else, that's something that needs to be taken really very, very quite seriously, because that's not somebody who's really able to utilize, good judgment or, their previous level of judgment before they were psychotic. And so they're really at quite high risk. Okay, so thinking about treatment, psychotherapy can definitely be first-line treatment for mild to moderate symptoms. It does not have to be first-line treatment. Medication is also a very reasonable first-line treatment, even for mild symptoms. But psychotherapy is a reasonable alternative, for milder symptoms. The important thing about psychotherapy is that it is a medical intervention in the same way as a colonoscopy is a medical intervention. Actually, that's not a good example, but it's a medical intervention, and it should it should have goals and it should work, right? Like we have data on specific types of psychotherapy that are structured and are, utilized in treating very specific symptoms and illnesses. So among those, there's a number of them, but among those, are cognitive behavioral therapy, which is an evidence-based treatment for depression. Interpersonal therapy is an evidence-based treatment for depression. These are structured treatments with very specific goals, and they should be time limited. Like the person shouldn't just be kind of showing up and talking forever. There should be goals. And we should see movement towards the goals. Indications for therapy as opposed to medication management would include, if the patient really has a very, very strong preference, again, milder symptoms, if we see that they, kind of have a pattern of maladaptive responses to specific situations and it's not sort of more generalized, that would be something that we would want to address in psychotherapy. And prior history of response to psychotherapy is another important indication. Supportive therapy, which is unfortunately, I think what a lot of people in the community get when they look for psychotherapy, is not really on its own shown to decrease symptoms. It definitely has a role in helping people with, in specific situations, but sort of, supportive therapy, and by that I mean, basically, the person will kind of come and vent, and they'll, kind of talk through, maybe practical strategies and coping skills. That in itself is really not shown to decrease symptoms of depression, but, it absolutely can be used to explore fears or reluctance to take medication. Medication can be first line for mild, moderate, or severe symptoms, and it's really clearly indicated for moderate to severe or recurrent symptoms, right? So, in somebody with really more moderate to severe symptoms, we wouldn't want to be using psychotherapy alone. We could be using psychotherapy along with medication. In somebody who has had a history of prior medication response, or specifically a family history of medication response, so, these illnesses run in families, and medication response can also run in families. And we really have a lot of data demonstrating that, we really get our best responses to a combination of medication and evidence-based psychotherapy. Okay, so how do you choose an antidepressant? So this is, I think this is, kind of what a lot of people were wanting to hear about. Really, no antidepressant is clearly more effective than any other. Right, there's no clear data that one is better, but on the other hand, they are not interchangeable. So in other words, if somebody has responded to one antidepressant and there's, some reason that they want to switch, or their doctor wants to switch them, we need to really keep this in mind, because even though they work by similar mechanisms, it is not clear that just because you've responded to one medication for depression, that means you'll respond to another medication in the same class. Often people don't. So, you should have a really, really good reason for taking somebody off an effective treatment. And empirical trials are really the only way to determine efficacy for a given patient. So, there's a lot of information out there, which I think is a bit misleading about pharmacogenetic testing. So pharmacogenetic testing is being marketed really, I think, in a little bit of a misleading way, in terms of, it being the best way to find the right medication for you. There's really no evidence that that's the case. Pharmacogenetic testing basically tells us how we metabolize medications that are metabolized at that particular P450 enzyme. So in other words, a use for pharmacogenetic testing might be, if you have a patient who you've tried on multiple medications at super low doses and they've had prohibitive side effects, we might learn from pharmacogenetic testing that, the patient is a slow metabolizer at the P450 enzyme that metabolizes those specific medications that you've tried. And then you might see, at which enzymes that patient might be a, more normal metabolizer, and then they, you could try a medication that are metabolized by those enzymes. So that's a use for it. It is often the case that people will come in having been told, I need to do, this gene-side testing, because that way it'll tell me like what's the right medication for me, and that's really just not accurate. I've unfortunately seen more than once a patient come in having been on an effective medication, and then for whatever reason the pharmacogenetic testing was done, and then their medication turned out like in the red zone, right? Like, don't use this medication for this patient, but meanwhile the patient's doing well with the medication and tolerating it, and their doctor switched them off an effective, well-tolerated medication because this wasn't the right medication for them, because that's what the pharmacogenetic testing showed, and then started them on something else that wasn't as effective. So that's really, really unfortunate when that happens. If we really have like absolutely nothing guiding us in any other direction, I'm going to talk about sort of what things we can use to sort of guide us in one direction or another in terms of choosing a medication. But there was a large meta-analysis done maybe 10 to 15 years ago, looking at efficacy and tolerability of multiple different antidepressants, and escitalopram actually came out, as the winner in terms of sort of the combination of efficacy and tolerability when compared to kind of the other medications we use. And so that, again, if there's sort of nothing pointing us in the direction of using anything else, that can be a very reasonable first choice. So what are the factors that can be helpful in terms of decision making? So the most important thing that I look at, and I think it really is truly the most important factor, is past history of response to a particular agent, right? It's also seems intuitive, right? If the person did well on something in the past, then that should be what you should start again if they're doing poorly. Again, it's really often happens that is not the case, but it's very, very, very important to ask about past medication trials and how the patient was doing when they were taking that particular medication. Family history of response can also be a guidepost. Again, depression runs in families, medication response can also run in families. And so if somebody, especially if they have a primary, a first degree family member who did great on Prozac, then that if the patient hasn't tried anything, that can be a good place to start. Other things to think about is, can we sort of kind of do double duty with the medication and target kind of other comorbidities? Like, are there medications that we can use to treat depression as well as something else, some other medical or psychiatric comorbidity? We want to think about populations that are vulnerable to specific side effects. We're going to talk a little bit more about that, and also cost is really a real factor. Okay, so we're going to first talk about populations vulnerable to specific side effects. So anticholinergics. So a lot of our medications do have anticholinergic effects. The tricyclic antidepressants are quite anticholinergic. Paroxetine is, less so, but it's definitely a consideration. Hydroxyzine is quite anticholinergic. And so we want to really think about avoiding those in people who are elderly or who are cognitively impaired, similar to benzodiazepines and Z-drugs. They're not, not absolutely contraindicated, but I would think several times before using a medication in that class in somebody who's elderly or cognitively impaired. We do see that among the SSRIs, citalopram causes the most QTC prolongation. And so if that's something that you need to be concerned about in your patient, that is definitely something to keep in mind. However, citalopram still causes less QTC prolongation than most of the antipsychotics we use. So that's sort of just a perspective. Bupropion. Bupropion actually, or Wellbutrin, is a medication that is, there actually has been some data, for full disclosure, there has been some data showing that there are people who do respond to bupropion for anxiety. So, if somebody tells you that they have had a positive response to bupropion in the past and it, either helped their anxiety or didn't make it worse, then that's a reasonable option. But I can't tell you how many times I've seen people with really severe anxiety be put on bupropion and gotten much, 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 much worse. That it is a medication that can absolutely exacerbate anxiety in a lot of people. And so that's, again, something that should be considered carefully. Second generation antipsychotics, all of them have the potential for metabolic concerns, metabolic syndrome, weight gain, hyperlipidemia, diabetes. And so those are medications that, again, we want to carefully consider, kind of depending on the patient. And basically all SSRIs and SNRIs can cause weight gain and sexual side effects. Like there's really, maybe paroxetine's a little bit worse, but in general, it's a class effect and it can happen with any of our medications. It's definitely something to ask about and to ask about sort of specifically, because it's not something people might either notice or disclose or connect with their medication. The other important thing that I like to tell people about in terms of weight gain is that I think often people, think or have read somewhere on the internet that they take the medication and then they just, they gain weight, right? So what's I think an important point to make is that these medications you don't put them in your mouth and gain 20 pounds. It doesn't work that way. Again, it sounds really obvious, but it's something that, I think often is helpful to clarify to patients. These medications will increase appetite or decrease people's sense of feeling full. And then, then they may gain weight. And generally it's actually gradual. If you look at the studies, which are generally 6 week studies on the SSRIs and the SNRIs, weight gain is really not listed among any of the side effects, again, because it's a very, very slow kind of insidious thing that takes more than 6 weeks to develop. And then cost. So really newer medications are really advertised very aggressively. And so patients will often ask you about them and, have the belief based on, I think, again, somewhat misleading advertising that these are better medications, that because they're newer, they're better. There's really no evidence of any increased benefit with, kind of the newer on-patent medications relative to our older medications. The lazodone is one of the newer medications. There may be some evidence and also some, conceptual reason to think that that medication may have fewer sexual side effects. It's really not clear, but it's definitely something that can be worth a try if your patient has tried multiple other SSRIs and has been limited by that side effect. Really, truly, the bottom line is there's no reason to use any of these newer on-patent medications unless as a first-line agent, right? After you've tried a bunch of other things, then perhaps. But there's no reason to use any of these medications first line unless the patient has a prior history of response to that particular agent. Okay, so pseudo-treatment resistance. So I see this all the time. People come in and they're like, oh my God, I've tried everything. I tried a million medications, nothing worked. Nothing is going to work for me. I'm totally treatment resistant. And then when you ask them some questions, which are the questions that I'm going to talk about now, actually often you'll find out that they've tried, either really nothing, they've tried a million things, but they've really tried nothing, or they've really had an adequate trial of very few medications. And it's very demoralizing for the patient, but it's actually very encouraging for me because I'm okay, we need to just do this right. And then I think we actually have a good chance of getting better. One common reason why people sometimes don't respond to treatment is they just didn't give it long enough. We really need at least 4 to 6 weeks, more like 6 weeks at a given dose to know if it's going to work. It is so common. And again, this is really very, very understandable for people to come in, after 2 weeks and be like, I'm feeling terrible, nothing is helping. Nothing's helping me. I feel horrible. I can't take it anymore. Please switch me to another medication. And sometimes the doctor will do that. But really that's the wrong decision because basically then they've just wasted 2 weeks, which is really not long enough for them to know whether the first medication is going to work. People will kind of jump from medication to medication without giving any medication a long enough time. Another interesting point is actually in, some of our very, very large trials, we see that there are some patients who really need 12 weeks. There is a subset, it's a significant minority subset of patients who had 0 response after 6 weeks, nothing, and they're totally in remission by 12 weeks. So, I wouldn't necessarily torture somebody and make them wait 12 weeks at each dose, but, if you see somebody who really does seem to have tried multiple medications and not had a response, that can be one strategy, is just let's give them a little bit more time and really see if they would respond with a little bit more time. Lack of optimized dosing is another major factor. People will often, kind of start on a medication and maybe increase the dose once. And then if they're not responding, they'll switch to the next thing. And that's not a trial. Then we've sort of, unfortunately, I think really wasted the time that patient is on that medication, because we don't really know. We just really don't know if they would respond to that medication at a more optimized dose. Sometimes people do need higher doses. Treatment non-adherence is another really, really important factor to really think about. And, that's something that people might, again, not notice that they're, kind of routinely missing their medication, or might not tell you. And then also, we want to think about, are we getting the diagnosis right? So other illnesses that can present with symptoms of depression that are not major depressive disorder, you might want to think about that more carefully if you see that, your patient really just is not responding to multiple adequate trials of evidence-based treatment. So, here are some, I just listed some potential diagnoses that you should really think about, in this case, where you would want to, kind of like do really a more thorough diagnostic eval to make sure you're getting the diagnosis right. So fine. So if you're not seeing really a response after at least 4 to 6 weeks, again, 4 to 6 weeks, you want to, first of all, optimize the dose before either switching or adding another agent, right? Like, yes, lots of people on, 5 medications, all at suboptimal doses. We're just sort of accumulating side effects, and we really haven't proven anything about any of them. We want to do diagnostic clarification when we're kind of screening for treatment non-adherence. I like to ask the question in this way: how many times per week do you miss your medication? It sort of normalizes the fact that everybody misses their medication sometimes, and you're kind of more likely to get, a closer to accurate response than if you say, are you taking your medication, or are you taking your medication every day, which patients may, interpret as judgmental and not answer correctly. Medical morbidities that can lead to treatment resistance. Really, the top 2 that we see are, what we call quote unquote subclinical hypothyroidism, which is an interesting term because depression is a clinical symptom of hypothyroidism. But be that as it may, we often see people sort of, in the range of like elevated thyroid function, such that primary care doctors or endocrinologists would say, this is really, not significant and not worth treating. But we do see that, these patients, especially if they're otherwise vulnerable, but even if not, that these are patients that are more likely to develop depression and will respond to, kind of more sort of rigid definition of thyroid normalization. Obstructive sleep apnea is a huge one in terms of leading to treatment resistance. Often, what we see really, I think, quite frequently is patients who are on medications, and it may work, and then it may stop working, and then they're switched, and then it may work and it may not stop working. And if they've got obstructive sleep apnea, that's a very common sort of history to get, that in terms of it like actually contributing to the treatment resistance, and that once the sleep apnea is treated, it becomes much easier to treat the depression effectively. Here, I just made a list of some, this is what I consider optimized dosing. Really, you cannot say that the person has failed a medication until we've achieved these doses, or if the patient has side effects and can't tolerate, these doses, then they failed the medication. But if they're tolerating the medication, if they're tolerating, Prozac at 40 or 60, you really need to take them to 80 before you can say Prozac doesn't work, and keep them at 80 for 4 to 6 weeks. So when should you add versus switch? So generally, again, this is not like, this is absolutely not carved in stone, and there's, absolutely like exceptions, all sorts of exceptions to this. But in general, if you have somebody on a medication, they're like really, definitely doing better than they were, but they're still not doing great. That might be a reason to say, I don't want to take them off this medication that's partially effective, and we'll augment with something to kind of make it work better. As opposed to if you're really seeing somebody on a medication and they're saying, like, I really don't feel any differently than I did in the beginning, everything's exactly the same, then I would, be more likely to think about, just taking them off because it's really not doing anything and switching them. Or if the person's having problematic side effects, then, then obviously, if the person's not tolerating the medication, then we need to get them off of it and switch them to something that's going to work better and they're going to tolerate better. Okay, so here's just some evidence-based augmentation strategies. Bupropion actually is super commonly used. Like in other words, somebody's on an SSRI and they're doing like, 70% better or 50% better, and then bupropion is added. It's actually not that evidence-based. There's really not a lot of evidence supporting its use, but it's very widely used. And, I think, I have personally seen it work quite frequently, so take that as you will. Buspirone is another medication that I think is often used for anxiety, but there's like really probably better evidence in terms of augmentation for depression. And then there are a group of second-generation antipsychotics that have been clearly demonstrated to work on augmentation. Aripiprazole is the one where we really have like the most solid data in terms of augmentation, in kind of appropriate patients. Okay, so managing side effects. So these are really, really common side effects that people have when they start these medications. It is very common when people start these medications to feel like their anxiety, not to feel like, but their anxiety actually often will get worse in the, kind of immediate, like a week or so after starting one of these medications. This will usually pass within a week. And so often I will tell people if they experience that side effect, if it's like intolerable, call me, but if it's tolerable, wait it out because it will likely go away. Another strategy can be just to sort of back up on the dose and go slower. It's often not the absolute dose, but more kind of the rate of increase that sort of, leads to the side effects. Sexual side effects, again, important to ask very specifically about sexual side effects because people will often not tell you unless if you ask. Sexual side effects are related to the levels of the medication in the patient's bloodstream at a given time, as opposed to the long-term effects of the medication, which are more related to, long-term effects on receptors over the course of weeks to months. And so because of that, timing can matter, sort of when the person takes the medication in terms of like when their levels are likely to be lowest. They're probably less likely to have sexual side effects in that time. Also sort of strategically skipping the medication, obviously not like super frequently, but that can also be a strategy. Add another sort of well-known strategy is adding either bupropion or buspirone actually can help counteract sexual side effects from SSRIs. I don't love to use a medication to treat the side effects of another medication, but sometimes, we really, sometimes we get there. And then really all of the medications, again, in this class can cause sexual side effects. No one is worse than the other, but it can be sometimes idiosyncratic. So there are people who can have sexual side effects on one and not on another, and then somebody else might have the reverse, but it can be worth trying to switch. So again, weight gain, it's often really helpful for patients to know that like it's not like it's a magic, weight gain pill that like just puts weight on them, but like if they're mindful of their diet and exercise, and they might need to be more mindful on this medication than they were before, but if they're mindful, it can sometimes be something that can be like managed just with behavioral strategies. Sedation, any one of these medications can cause sedation or activation. It again can be quite idiosyncratic. If the medication's making the patient tired, then I think the first thing I would do would be to switch it to bedtime because then they'll be tired when they're sleeping, and that's a good thing. Okay, emotional blunting is another really common side effect. And by that, I mean, people will complain that they just like feel blunted overall, like they're not sad, but they're not like able to really experience happiness either. They're not able to feel sad appropriately, like they used to cry at like sad movies and they don't anymore. They used to cry at weddings and they don't anymore. And that's not something that they want, and it's not something we want either. And often people will sort of get confused, understandably, with the therapeutic effects of the medication and think that that's our goal, and it's really not our goal, it's a side effect. So, it's often dose dependent, and people may be less likely to have those side effects on lower doses, or again, also perhaps switching to another medication because it's idiosyncratic can be. Okay, so when we do think about switching, often it can make sense to switch to a different class, especially if the person has failed, say if they failed 2 SSRIs, we might want to say, we might want to not switch to a 3rd SSRI, but we might want to switch to a medication in a different class. And really, actually, there's a lot of evidence supporting switch to venlafaxine, like in that population in particular. People who have failed 2 SSRIs are really much more likely to respond to venlafaxine than they are to a 3rd SSRI. Okay, and then this is the question, I know I get all the time, if I take this medication, do I need to stay on it for the rest of my life, right? So like, it's a reasonable question. It's a really important question. I think it really depends on a lot of different things. Ideally, under like pretty much all circumstances, we want to treat for at least a year before even attempting to taper, because we see that really that's the time of highest risk in terms of, recurrence. When do we want to keep somebody on chronic treatment? So, if somebody has had just one episode and, perhaps it was in the setting of specific stressors and now things have changed in their life, that can be a setting where it can be reasonable to think about trying to take somebody off an antidepressant. It really sort of depends on recurrence and chronicity. There's pretty much clear consensus that if somebody has had more than 3 or more episodes, then that's somebody who really should continue on treatment indefinitely. But it's obviously always a conversation. And the dose that gets you well is the dose that keeps you well, right? So people who get well with a medication, if we have decided that they need to stay on that medication, they will likely need to stay on the same dose of that medication. There's not a lot of evidence that, kind of once we've gotten through the acute phase, again, in somebody who requires chronic treatment, that we can lower the dose and that will be. Okay, so, goodness, I can talk about postpartum depression, or we can stop now and have questions. Zaret, what are your thoughts?
I think we are running out of time tonight.
Okay.
So there are questions in the Q&A box, so we can go over those. The first question asks about the role of suicide screening questionnaires, and it says we use ASQ suicide aged 11 and up in their practice.
Okay, so I'm sorry, so what's the question?
It asks about the role of suicide screening questionnaires.
Like, what is the role? So yeah, I mean, I think, I would think about it in the same way as I would think about any other screening questionnaires, or it's a screening tool, right? So in other words, what you're doing is you're looking at sort of a general population, and you're kind of picking out the people that you want to ask more questions to, right? So in other words, I wouldn't like make a decision or institute an intervention based on a screening questionnaire alone. And if you had somebody who, similarly, a patient who you were concerned about who scored, didn't get a significant score on their screening questionnaire, I would ask that person a question as well. But again, it's really sort of a tool to kind of filter out the people that you want to kind of ask more questions to.
Okay. The next question, a lot of patients complain of not feeling like they're all there, or like they have a foggy feeling when placed on meds. Does that feeling go away?
Okay, right. So that's exactly what, I'm sorry if it wasn't clear. That's what I meant when I talked about emotional blunting. So yes, the emotional blunting is often described in exactly that way. It's sort of this foggy feeling that they're not like really totally all there, that they can't experience their emotions in the same way as they used to. It is often the case, sometimes it'll go away, but if somebody is having that symptom and it, has persisted, I wouldn't necessarily assume that it's going to go away, and I probably would intervene. Again, I think often people will sort of conflate like what we're trying to accomplish with sort of that blunting, and they'll be like, oh, medications are terrible because like I can't feel anything, and that's not what we're going for, right? That's a side effect. We want to address it in the same way as any other side effect. If it's problematic or intolerable, we need to make a change.
Okay, once a patient has sexual side effects, if they stop the meds, will the side effect go away, or is it there forever now?
No, 100%, it will go away. And that is actually, it's kind of even more so, right? Again, the sexual side effects are related to blood levels of the medication in the person's bloodstream at that given moment, right? As opposed to the therapeutic benefit of the medication, which is, kind of more, effects on receptors day in and day out for weeks or months. So actually, even like skipping a day or two of the medication can make the sexual side effects go away for that day or two, as opposed to, if somebody misses their medication for a day or two, they're not likely to relapse. If they miss their medication for a week or more, then then they may. But often, in terms of the therapeutic benefit of the medication, it takes the same amount of time for it to stop working, which is about 4 to 6 weeks, as it does for it to start working. Sexual side effects are really just like in that moment in time. So absolutely, if you stop the medication, the sexual side effects will go away. And often, even if you just skip it for a day or two, they will go away for that day or two.
Okay, that's good to know. A lot of women experience depressed mood on combined oral contraceptives. Is it reasonable to put them on an antidepressant?
That is a great question. It's true, right? So when we look at the population as a whole, people who are on oral contraceptives don't necessarily have a higher risk of depression than people who are not. So in other words, it shouldn't be a reason, like with no other information, not to take an oral contraceptive if you were otherwise wanting to take one or needing to take one. But there clearly is a subset of people who respond poorly to oral contraceptives that, when they take oral contraceptives, they will develop psychiatric symptoms. There's likely some overlap with people who have, symptoms in the postpartum period and symptoms in perimenopause and kind of other like hormonally significant times in their life. And so again, it's sort of, I think it's really a very individual question. So in other words, if this is somebody who was already having depression and their depression got worse on the oral contraceptive, then, you'd be treating their depression anyway. And so you might want to, continue the oral contraceptive if needed and treat their depression. On the other hand, often people don't absolutely need to be on oral contraceptives. So it really depends on why they're on their oral contraceptive. And, often people will choose in that situation to stop the oral contraceptive so that, their symptoms don't, for that particular person, don't get worse. But then there are people who, really, really do need to be on the oral contraceptive. Like, for example, they have really, really bad endometriosis and they're in horrible pain if they don't, take the oral contraceptive. That would be a situation where we might just say, like, okay, like, you need this medication, we're going to treat your depression.
And for the last question of the night, what is there to do other than antidepressants during perimenopause when it's common to develop depression?
That's a great question. These are such great questions. So yeah, I actually have a whole lecture on this. Perimenopause is a definitely very clearly higher risk time period for women, like it's very, very clear that that's a higher risk period, both for women with a history of depression and women who don't have a history of depression. Both categories of people are at higher risk during perimenopause. Antidepressants actually, have been shown to be very, very helpful in that setting. I would, if the person's been on an antidepressant before, again, I would choose the one that's worked for them. In the absence of that information, actually, Effexor or venlafaxine can be, there's some data that can be quite helpful in this phase. Actually, also hormone replacement therapy, specifically in the perimenopausal period. And again, risks and benefits, and it's an individual conversation to have with your doctor. But hormone replacement therapy specifically in the perimenopausal period can be helpful with symptoms of depression. What's actually interesting is that when people actually get through menopause and they're postmenopausal, estrogen is no longer helpful. It's no more helpful than placebo. But specifically in the perimenopausal period, we do see that estrogen can be helpful.
All right. Thank you so much for speaking tonight. This is such an important topic. This is a really important topic, especially for primary care physicians to know more about. So this was very informative.
Thank you.
Thank you to everyone for joining us tonight. All right. Have a good night, everyone.